Okay, great. Well, good morning, everyone. Especially good early morning to those folks out west. And Matt, thank you again for allowing me a little bit of time this morning to share with y'all, especially given what was said at the beginning about the concerns about our emotional well-being in this day and time. I'm going to share just some general thoughts about mental health before we get into the specifics of the presentation. As Matt indicated, I've been doing this for a little bit over 30 years. And currently, while I still do see patients, our organization, the National Center for Performance Health, presents a little bit of a unique approach to the concept of mental health. And that is this: when I'm speaking publicly, I say that there's three basic challenges to the topic. And that is, number one, is the stigma and the associated denial with it. Number two, it's the fundamental lack of education and awareness. And then number three is a lack of access. Now, as part of athletics, especially professional athletics, your teams and your organizations have access to mental skills professionals, psychologists, hopefully psychiatrists like I am. I am an MD, and I mentioned that to you because there's still, even in this day and time, is a fair amount of misunderstanding, confusion. Mental health very frequently gets lumped into one kind of category. Okay, well, we got the mental health person over here. Well, there's varying degrees of experience, of training, credentialing, that really can have a profound impact on outcomes when we're talking about either individuals or organizations. So I would encourage each of you to think through for your own organization that hopefully you have the appropriately credentialed, licensed, verified people. Unfortunately, this is my opinion in this day and time as a psychiatrist, someone who has gone to medical school and spent 5 years in residency training. Very frequently, when there's complex issues related to patients going on the mental health continuum, we are the last ones to be consulted. And it's a fascinating reason as to why, but we'll save that for another day and time. So I did want to mention those general thoughts with you all. So let's look at the title of the presentation: a biopsychosocial approach to understanding disordered eating in males. I want to examine what the term biopsychosocial means. And Wendy, I know you and I did not have a chance to speak prior to this, and I apologize to you for that. But there's so much of what you said is what I'm going to be discussing as well in terms of connecting the points here. So when I am talking about biology, and this is a way, Matt, that you just made this comment earlier, is that this conversation today is not intended just to necessarily focus on athletes, but is to look at ourselves and our families and how, either as healthcare professionals or coaches, whatever your role is in the community, to take some of this information, and hopefully what it leads to is a little different approach to understanding people and individuals when you're looking at their emotional well-being. So the biological part, in my opinion, refers to our genetics. What is our genetic composition? Just like hair color and eye color, we inherit the neurochemistry of our brain. Now, there are certain elements of the neurochemistry of the brain that can be changed and modified, but there's a fair amount that is fixed. And we should always take that into account because there are certain conditions that predispose individuals. If a primary relative in their family, such as a mom, dad, or sibling, had a psychiatric issue, that individual is at higher risk for having that same condition. The other part about the dimension of biology has to do with the fact of, for example, of what type of medications are you on? Do you have an underlying medical condition such as diabetes? And we'll talk a little bit more about that. The psychological part of things is related to our self-esteem. How do we feel about ourselves, our sense of self-worth? What are our beliefs, our attitudes? The social part of things has to do with our social relationships, our social supports, our socioeconomic status. These types of, what type of school are we in? Are we in if we're talking about high school students, are we in the right academic setting? Do we potentially have an underlying learning disability that may be impacting our behavior and our worries and our sadness and our anxiety, because all of those things are predisposing risk factors to disordered eating in individuals, whether they be males or otherwise. So I wanted to mention that to y'all a little bit in terms of what we were talking about with the biopsychosocial approach. So again, a little bit about my background. Matt already alluded to this. So I still do currently work in foster care, which I have been doing for a little bit over 25 years. Major League Baseball, formerly with the Tampa Bay Vipers, a little bit of consulting work for the NFL and NFL Players Association. We also have created a very unique program called Game Changer for collegiate student athletes, and we service that out of our Gaffney, South Carolina office. As Matt said, we're also based in Tampa, Florida as well. So a little bit about our organization. When I said to y'all earlier that we take a little bit different approach, and I think that this is one of the things in related to emotional well-being and psychiatric care and mental illness is missing. You know, we are very focused as clinicians to treat, and there is nothing wrong with that. We need psychiatrists, we need therapists, we need registered dietitians to be able to treat these conditions that develop. What we spend very little time on is looking at how can we potentially prevent some of these things from developing in the first place. And that's what I'm going to try to spend a little bit of information on this morning with y'all, because it is that preventative, proactive approach that can make a difference. Because when you look at a bell-shaped curve, we are looking at the greatest risk for people ultimately for suicide, right? And on that bell-shaped curve to the right-hand side is where people who are developing actual symptoms and need that treatment. But what we are doing is that we are not focusing on that other dimension of the bell-shaped curve, where people may be having some difficult experiences in their life, like i.e. a pandemic, right? Which is a risk factor at this time for all of us. It doesn't mean that we're all going to develop a bona fide mental health condition, but what we do need to have is awareness and be educating parents, coaches, owners of teams about these types of things. So here on the list is just a little bit of what we currently do as an organization. We provide licensed therapists 24/7, 365 to our various clients that we serve across the country. We're also involved in a unique program here in the state of Florida that involves telemedicine needs provided to pediatric psychiatry patients that may need some consultation. One of the things not listed on here that I'm exceedingly proud of that we're doing right now is called emotional vaccines. These are brief 2 to 3 minute videos that we are creating internally and producing internally as a way to get some of this proactive education and knowledge for self-care and parenting support out to the general public. So our learning objectives, prevention through education, identifying some risk factors, presenting signs and symptoms, comorbid diagnoses, and treatment options. So what I've chosen to do this morning is to take a case study for you all, and I will read through it in case there are folks that may just be on the telephone. So let's say you are the registered dietitian for the reigning World Series champion LA Dodgers, and a very astute pitching coach who has been well educated on emotional wellness comes to you regarding an 18-year-old on the team, a high profile, valuable recruit, just made it to the team. The coach has observed, and the recruit's name is Joe, of course, de-identified, that he's noticed that every time after mealtime that he goes to the bathroom after he eats. So as part of the robust clinical team, you decide that you're going to, as Wendy had outlined, that you're going to go to your team physician and find out what he or she knows or thinks or has any knowledge of. So Dr. Welby, the team physician, says to you that, well, Ed, that's interesting that you came to him because he has noticed that Joe's serum amylase was quite elevated. Serum amylase is a biochemical marker that's related to people who have eating disorders related to the salivary glands. When there is frequent vomiting, this may be a presenting sign of someone who has an eating disorder who is making themselves sick. And so in Dr. Welby's situation, he thought, well, this is probably just a lab error. So he ignored it. So eventually you decide to meet with Joe, and Joe comes off as a very nice, polite young man. But however, even though you're a registered dietitian, you're savvy enough to know that there's something else that's going on beyond just him having a sad face, but he's endorsing some symptoms consistent with depression. Because in your knowledge, you clearly understand the linkage between the mind and the body, because for so long, and this is why diet and our eating habits are so critical to our emotional well-being, is for so long, we have separated out the mind-body connection. The two are actually very much related. So Joe reports to you having stomach issues each time after he eats. And he says he feels an uneasiness for the last 6 months. He feels anxious and uncomfortable at eating. And he reports to you that he feels he is overweight when actually he is ideal body weight. And he says to you that feels like he needs to lose about 10 pounds. He admits to making himself sick, which is a profound statement to make, because very often people who do have formal eating disorders do not acknowledge this, but he is acknowledging this to you. That's a very important sign in terms of prognosis, that he is admitting what the challenges are. And so he also acknowledges simultaneously that he has physical discomfort during this. And he also reports to you that about 5 years ago, before he came to the Dodger organization, 5 months ago, that his coaches knew that this was going on. So in Joe's estimation, he believes that these most recent symptoms related to 6 months ago or so started happening when he reconnected on social media with a previous foster care family that took care of him. And Joe's past medical history is significant for the fact that he was full term, but at 8 months of age, he was placed in foster care for about 3 years. His father had been deployed to Iraq, and his mother became addicted to narcotics and was unable to care for Joe. Eventually, she regained custody of him. Now, it may sound like to you all that these various points that I've mentioned in this history, but these are also very commonplace things that happen. They may or may not necessarily all happen together, but they happen in people's lives. And what happens, though, is that we may not necessarily know that they've happened for, again, a multitude of different reasons, one of which I alluded to in the very beginning, and that has to do with stigma. So a little bit more about Joe's history is that up until eight months, he had been developmentally on target with his milestones. However, when in foster care, which is, again, something very frequent that happens, his development did begin to regress, both emotionally and physically. At age 5, his parents divorced. At age 6, he develops juvenile diabetes, which means he requires insulin. And in March of 2020, right at the beginning of the pandemic, his father passes away from COVID. Joe has been highly recruited by the Dodgers organization, and currently his high school coach, even though who had knowledge about this, is very supportive of him. Okay, so let's try to assimilate what all this may potentially mean. So remember what I said, that one of my agendas this morning, hopefully for you all, is what you take away is thinking through prevention before there's even a problem, right? Remember I said stigma, number 2 was a lack of education and awareness, and number 3 was a lack of access. Lack of access, meaning lack of access to qualified mental health clinicians who are trained, licensed, credentialed, and experienced in working with children, adolescents, and even potentially adults. So look at these facts. So 50% of lifetime cases begin by age 14. What this means is that when a young adult in their 20s or age 18 or 19, like in the case of Joe, who may then be formally diagnosed with a anorexia or whatever the condition may be, symptoms have already started manifesting themselves by age 14. But what happens is, because of the lack of awareness and education, or even what do we all do about this, type of thing is what impedes an individual from getting the help early on, because the median length of time between when symptoms of a depression or potentially an underlying disordered eating condition, when those symptoms initially present from the time that somebody actually gets help, can be, in some situations, up to 10 years, especially for depression. Disordered eating may be a little bit less. So this is why early identification is very important. 50% of students age 14 and older with a formal psychiatric illness drop out of school. And 70% of youth and juvenile justice symptoms have a mental illness. This becomes relevant for all of us as members of society, because it is these young people who are sitting incarcerated in various facilities and then as adults in our jails. So risk factors. Let's think back about the case with Joe. What are the biological risk factors? Remember, I said earlier that it has to do with our genetics, it has to do with our medical conditions. So if we look at those two things, biologically, right, his mother became addicted to pain medications. He also has a biological risk factor in that while he was in foster care, potentially did not receive adequate nutrition, adequate stimulation. All of that can affect the development of the central nervous system. When the central nervous system gets impacted, that's what impacts the neurochemistry of our brain, the various neurotransmitters in our brain. It is those neurotransmitters that impact our mood, our eating habits, our sleep. All these things are risk factors later on, right? When we incur traumas later on in life, it is that foundation that is laid, especially between the ages of 0 to 5, for our biological, psychological, and social well-being. So those are some biological risk factors. Psychological risk factors are, now stop and think that he was placed in foster care. So even a child at that age is going to be impacted potentially at age 8 months in terms of their self-esteem, in terms of their self-worth. If they are not getting the adequate, appropriate type of attention in any family of origin, this is why this kind of knowledge is very important in understanding that individual that is sitting in front of you. The social part of things. We've just learned that his father passed away in March of 2020, who was very supportive of him as a direct result of COVID. So all these major life events have happened. Now, this does not mean that because of all these things have happened as risk factors to Joe, that he's necessarily going to or develop a condition. It just means he's at risk. And this is what I'm trying to impart to you all, is to thinking of a global way to kind of think about individuals, actually from a public health policy, which is very much missing right now when we talk about mental illness and mental health. So one concept central, if there's nothing else you remember from what I'm talking about this morning, is please, for those of you that are not aware of the concept of adverse childhood experiences, let me explain what this is about. This came about from a study that initially started between 1995 and 1997 between the Kaiser Foundation and the Centers for Disease Control. So they looked at about, I think it was about 1,700 adults who would come to clinics as part of one specific health plan. When they came to these clinics for a general physical exam, they had identified a questionnaire identifying if those individuals, that adults, had incurred any of these types of events: abuse, neglect, and household dysfunction. And what we determined is that, or what they determined was that about 60% of all adults have incurred one dimension of an adverse childhood experience. Now, there's more details. Some of the household dysfunctional topics that are listed are referred to as a parent who may have a substance abuse issue, as Joe's mom did, or there's been divorce in the family, as happened in Joe's family. He also incurred potential neglect and maybe even abuse. The significance of the adverse childhood experiences, again, as a psychiatrist, I want to be very clear on this. It's not my agenda or my interest to start turning people into individuals, into patients. That's not what I'm saying. What I'm saying is we want to have that knowledge where we identify people very early on and potentially get them the right kind of help that they may need. And so the most significant finding of this study, number one, was that people who endured adverse childhood experiences were more likely, obviously, to have a risk for developing psychiatric conditions. But the greatest finding was the fact that these people who incurred these adverse childhood experiences were also at greater risk for developing medical conditions such as diabetes, asthma, heart conditions, very much tied into our emotional state and the events that we incur. So we've already talked a little bit about this related to Joe in terms of the biological presentations related to his specific situation, where we had the elevated serum amylase level. We probably had some what we call neurovegetative signs of depression, meaning sleep disturbance, depression, depressed mood, alterations in appetite, psychological, where remember he says that he feels like he needs to lose weight. That is tied into everything that Wendy talked about with the issue of society and the demands and the pressures that are placed on males in particular about bulking up necessarily. And then the social signs and symptoms where he's lost his father. He has a supportive coach, which is very important and something very important to draw upon as we're seeking solutions for Joe. The other thing I wanted to mention is that very often in individuals who do have formal diagnoses of a disordered eating situation, they may also have what we call comorbid diagnoses like Joe with mood disorders. They also present with anxiety, other medical diagnoses, right? Remember we said that he has diabetes. Individuals who have diabetes are, whether it's even insulin dependent or non-insulin dependent, are 2 times more likely to develop a comorbid mood disorder with that. And again, that's where that mind-body connection exists, because even treating one and getting one better, we also need to try to focus on the other one as well. And also people with disordered eating are predisposed to conditions of substance abuse. So what are the treatment options in Joe's case? Number one, biologically, right, is the critical part of the diet, of the nutrition, especially if he or she is an athlete that working with the dietitian on the team or in a clinical treatment setting to ensure, because as Wendy alluded to, these folks and individuals are very high risk for morbidity and mortality with these conditions. And that has to do with very often cardiac arrhythmias, electrolyte imbalances, and other things that they suffer from, which can be very serious. So the treatment, again, is restoring their nutritional state, potentially using antidepressants if indicated. Psychologically, getting them in cognitive behavioral therapy. Again, this is something that's beyond, no disrespect to people doing mental skills. This is beyond mental skills professional, where there needs to be a licensed clinician that is helping with this condition. The social, this is in the treatment of mental health conditions in 2021, after doing this for over 30 years, both with children and with adults. I will say to you all, this is the greatest missing link, is that where we don't look at that in that individual in terms of their social being, who is significant in their life, are they educated about their diagnoses? Is there adequate communication between the medical professionals involved in that individual's care? I see this happen all the time. Fortunately, in my situation in Major League Baseball, as a physician for the team, I have a great relationship with a licensed clinician on the team, and we speak frequently, but that is not always the case. Very often in professional sports, the psychiatrist is marginalized and outsourced and viewed as the one that's just prescribing the medication. And that is a very dangerous way of viewing things, because potentially a psychiatrist to your organization can bring in a lot more. So that's the end of the formal presentation. So let me stop right there, because I guarantee you that I was not as good as Wendy in terms of monitoring the time. So my apologies.
All right, Doc. Well, if you could just stay on, we'll try and get, for time purposes, we'll try and get a question in or two for you and Wendy. If you could just unshare your screen so we can get and then get Wendy back on. And then get a chance to go through this, and I'll look to see if we have any questions in there. I don't know if Frank's still around. Frank might pop back on as well.
Guys,
But for Wendy, I want to let you know, like over my years, I've seen many times where potentially the front office or the coaching staff might use weight as the number one factor when they're evaluating a player, especially young players or a player we might just got traded over mid-season. And let's just say they were in their own way slightly overweight, but they're pitching well, right? And everything's good until they're not pitching good, right? And then all of a sudden, all the questions keep coming. And so if he's the exact same weight and he's pitching great, and all of a sudden one bad start, that's the reason why he was pitching bad. And then all these questions start coming, and next thing you know, it's like, what are you gonna do? And all of a sudden they're bombarding it. And if it's a young player, I've watched this go negatively on their performance very quickly because they just don't know how to handle that. They don't know how to keep everybody at arm's distance yet. And an older player, maybe someone who's under contract or whatever, who's been around a little bit, who's been talked to in that way once or twice, like, they know how to like shield themselves. But it's detrimental to young players.
Absolutely. And if you talk to the guy, which I've been around pro sports for a really long time, you can really quickly hear he had a bad game because he was up all night playing video games, right? Or there was something that happened. He had a terrible, there was something in his personal life that happened. And now you've got the whole front office freaking out about this guy's weight, and everyone wants him on a diet, and it all got focused on weight. And I think to your point, like, he was doing so well at that weight before, and maybe even he played in college at that weight, and he was drafted at that weight, and and he was drafted under the assumption that they would have him lose weight, and so it's kind of crazy. It's like, it's really important to understand the habits. What is the guy doing, right, before everyone is focused? Like, I was going to show a video clip, but this time period was so tough. I had a video clip of Chris Jenkins from the New York Jets, one of the guys I worked with, and he was describing in his own words his frustration with his weight goal and compared to one of the other guys on the team, and how his body fat percentage was so much lower, even though he's in a bigger body. And, this whole, there's just so many factors that go on.
Right.
Wendy and Doc, I know we want to be mindful of the time here, but what are your thoughts on, and I don't know if it was brought up in your talks, of really being a good teammate? A lot of times the practitioners that are in the clubhouse, and you may not be able to identify some of these signs and symptoms where, teams are, they're closer, teammates are, and when you know that one of your teammates is maybe going through some level of a disorder, to be able to, to connect the dots and get that athlete, get your friend and your teammate to the appropriate professional to help them. Is it something you encourage amongst your clubhouses and your teams, or how does your experience with that go?
Sure. So I'll jump in. I would say, and thank you for that question, Frank, really appreciate it. Let's say that an individual is noticing that his teammate is engaging in these similar types of behaviors. We would say absolutely. Maybe the first step would be for that teammate is to go to the mental health clinician for the team, and without necessarily giving the individual's name, is say that he is concerned and what suggestions does that mental health clinician have. Because one of the things we need to be very careful of is for those folks who do not carry licenses, is coming up with a diagnosis and someone's saying, hey, I think he's got an eating disorder, or hey, I think he's got an addiction to alcohol, right? We want to be very careful of that. But the only way that kind of happens, Frank, is as an organization, if there's a culture that's created to openly be able to discuss things, right? I mean, we're obviously not there with the point of stigma at the same time, but more as a practical thing. And if it's somebody that's a coach for a high school team that is noticing a 15-year-old, that there's some behaviors there, again, is to gently go ask someone else without saying that, somebody else that might be involved in the adolescent's life, and then ultimately sharing that concern with the parent, not with a point of view of making accusations or saying that I think your adolescent has an eating disorder, just saying, hey, have you noticed this? I'm just letting you know I'm concerned about that. We have to be very careful and delicate with that, but that is, I think, the best way to try to address this.
Good.
We have one more question here. For Wendy, do you see the guys that are binge eaters? Do they also are binge drinkers? On the other end of that, I mean, do you see the same guys that abuse food, do they abuse alcohol, or is it vice versa, or is it one or the other?
Yeah, maybe. We know that there's a lot of alcohol consumption in sports in general. And so it's something I talk about with a lot of my athletes always. It's something I screen for. It's something I ask about. Sometimes they're honest. Sometimes they're not honest. I mean, I think sometimes they think they're going to get in trouble if they talk about it. So you really have to develop a good relationship in order to get a good relation, a good answer. But it's not always the case that a binge eater is a binge drinker. I mean, substances are a different category. And so it's hit or miss, I think. I'm not sure if, Dr. Mira has a different slant on that.
Yeah, I mean, there can be definitely a propensity towards that compared to somebody that does not have that same, binge eating type of behavior. But yeah, it's very difficult to make some absolute concrete numbers associated with that.
Well, listen, interesting topic. The lot we can go talk about this because we probably a lot of different experiences and from personal through professional. But I don't see any other questions in the hopper right now. But I do appreciate your time, and we're going to move forward. We're going to take a 5-minute break for the vendors, and then we're going to move forward for our last block, and then we'll do. We'll meet Eric and John from the NSCA and the NSF, and then we'll have our closing remarks. So I appreciate your time. Thank you very much.
Thanks, Wendy. Thanks, Doc.
Thank you.
Thanks so much.
Great job.